Yay, we're recording again. All right, so next I would like to bring on Tim. I get this backwards. So Tim Black from Whitebird Clinic, all the way out in Oregon. And I am so thankful and excited to have him on. He is going to talk about what Whitebird Clinic does specifically in regards to CAHOOTS. To my knowledge, this is the nation's leading mobile crisis program. They mentor other cities that are trying to implement the same thing. And anyone who knows me knows that that is like the number one priority of mine for the city of Cincinnati. So Tim, thank you so much for joining us. I can't tell you how much I appreciate it. Thank you, thank you, thank you. I'd love to give you just some time to introduce yourself as well as Whitebird Clinic and maybe just give a little historical background of the clinic in CAHOOTS.
Sure. And good evening to everybody. I'm really excited to have this opportunity to, really kind of come and visit you from Oregon so quickly. That's been one of the benefits of the pandemic is this opportunity to really engage and build community in a lot different way. So my name's Tim. I use he, him pronouns. And I do represent the Whitebird Clinic, which operates the CAHOOTS program here in Eugene and Springfield, Oregon. Whitebird Clinic is a federally qualified health center, so we have a lot of different services, not just the CAHOOTS program. And really, it's our connection to that greater system of care that allows our teams to be so successful. But we're talking about CAHOOTS today. So CAHOOTS is an acronym. It stands for Crisis Assistance, Helping Out on the Streets. And while the CAHOOTS response officially started in 1989, our organization started to do community-based crisis intervention back in 1970, really recognizing the inadequate resources in relative to the level of need in our community. Our founders wanted to find out what was really working well in other communities. So they spent time down in San Francisco at the Haight-Ashbury Free Clinic, up in Portland, Oregon at Outside In, and then brought those lessons learned from those larger cities back to Eugene. And we opened a crisis center. And before we even had a brick and mortar location, we had that phone that people could call, that hotline. And that's where we started to see this immediate need for a community-based response. And so for almost 20 years, we did what we could with volunteers who would respond to calls from the crisis line. We had a brown paper bag of first aid supplies in it, and you went out in your own vehicle, and we would meet people where they were at out in the community, and really just try to do what we could to support those individuals in addressing their crisis without necessarily needing to go somewhere else. This goal of really trying to find that resolution and kind of brief stability where you were in the community. At the same time, we had this crisis center that was becoming more and more utilized by law enforcement as a diversion resource, as an alternative to taking someone to jail or even to the hospital, knowing that for a lot of situations, taking somebody to the crisis center where they could talk with Whitebird staff for a few hours while they worked through that acute situation could really, create a lot more positive outcomes, especially in the 70s as folks were experimenting a lot more with psychedelics. If they had an adverse experience with that, they went to the hospital, chances were they were going to get sedated with Thorazine, which then carries the risk of tremors and seizure once they got out of the hospital. Now you compare that to somebody who can sit with you for 6-8 hours while you work through that really challenging experience. You can have a lot, better outcome. We also were really seeing early on that there was an intersectionality between physical health and behavioral health, and that when somebody's in crisis out in the community, it can be really hard to parse those two things apart. So what if we had a response that really met that intersectionality and treated you as a whole person, regardless of what you called in to say was your chief complaint? So through that interaction with the public, through showing them that we would show up where they were and really meet them where they're at, literally and metaphorically, and showing our value as a diversion resource to the larger public safety system in our community, we were able to work with the city of Eugene using funding from a community policing grant to take this kind of ad hoc volunteer-based service and turn it into a new branch of public safety in our community. By utilizing the public safety non-emergency dispatch system, by having access to a lot of other resources that are generally reserved for traditional first responders and law enforcement, fire and EMS, right? We were able to all of a sudden have this profound impact, not just on those who knew to look through the yellow pages and find the Whitebird Clinic crisis number, but anybody who was calling into 911 or to the non-emergency line. All of a sudden there was opportunity to have a behavioral health first response instead. We started off real small, only 40 hours a week, and we've only grown our services now. We are a 24/7 service. We respond to over 20,000 calls annually between our two cities, which has a combined metro area of about 250,000 population. And we're saving our community $17 million a year by keeping police and fire and EMS out of these situations that don't require that kind of first response, and instead really, bringing folks out in our community, what they really need in the public safety system. And I could go on for hours to talk about that, but I know that there's some more focused discussion. So let's dive in.
Absolutely. So while Morgan and I were talking earlier, that was, more specific to Ohio as a whole.
Mhm.
However, this is open to anyone in Ohio, because I'm sure I'm not the only person in Cincinnati or even another city in Ohio who's interested in more of this, and bringing this to their city. But for our purposes, we're going to kind of talk about kind of like Cincinnati, Eugene, all that, keep it kind of local, because I can only be sure of what's going on in Cincinnati at this time. So just a little context for you, Tim. Our police department responds to a lot of mental health crises. I've been digging through the data for months and months and months. But yearly, our department responds to about 8,000 mental health related calls per year. I'm sure it's more, because their system of like classifying things is really interesting. We have a mental health response team, so a pretty big team of officers who go through additional training for like de-escalation and things like that. So if they respond to that call, then it's considered a mentally impaired call, which is where the 8,000 number comes from. I don't think that includes like addiction. I don't think that includes homelessness. I don't think that includes a lot of youth calls. But we're working with a number of about 8,000 annually. Of that, 4,000, about half is deemed nonviolent. So in my eyes, I'm like, okay, that's a huge window, for us in Cincinnati to be sending other equipped individuals to go in and handle that situation. Because, like you mentioned earlier, I think a lot of people look at de-escalation, and it's very, very, very easy to oversimplify the issue. Even our own police department, and this is not to dog on them, from my understanding, a lot of what they learn to do is to use empathy and active listening, which is great. Everyone should learn to do that. Those are not the only two components of successful de-escalation. And as you noted earlier, it can take hours to successfully de-escalate a person or get them stable, at least if they're not hospitalized. And that is a completely unfair thing to ask our police officers to do. Hence why I am trying to push for mobile crisis units here in Cincinnati. My vision is, because we are very not into tax increases here in Cincinnati, understandably. And right now, I don't think that we have a single mental health clinic or provider, or even a hospital provider, who is big enough to handle something as big as this. In the future, that may be so. But right now, what I'm trying to do is to make this something that is part of our city's health and safety unit. So this comes out of our safety budget. It's city operated, like it has the City of Cincinnati name attached to it. And, of course, a very valid question that people have in that regard is, how much is this going to cost, and how specifically are you going to fund it? Which leads me to CAHOOTS. How is that funded? And do you mind me asking, typically, what is your operating budget as of late?
Yeah, our operating budget for the 2019-2020 fiscal year came out to $2.3 million. We receive about $1 million from the cities that we operate in. So that's Eugene and Springfield, which are, right next to each other there. We also receive another 50,000 from our county's Medicaid provider. And that really is a recognition of our cost savings to Medicaid in our community. We also have to fundraise a significant amount, $500,000 to, $750,000 a year. And that really, a lot of that fundraising goes to address the underlying issues that precipitate many of our crises that our patients are experiencing. So often, what we're encountering is really just, a confluence of unmet need on top of unmet need, right? On top of, whatever. And when we can address the lack of access to nutrition before we start to talk about the emotional side of things, right? That takes financial resources to have food that people can actually digest and eat. Eugene has one of the highest rates of homelessness per capita in the United States. It also rains 370 days a year here. And so we need to have, things that aren't caught in layers to be able to give out to folks so that if they are, obligated to spend a night out on the streets, that at least they'll be able to survive that without worrying about cold weather exposure on top of everything else. So it's a fairly diverse but still pretty threadbare, operating budget that we have here.
So if I'm hearing you correctly, you get about $1 million from the 2 cities that you operate in. You get money from Medicaid as well. And part of that is because you're saving Medicaid money. So it's like, here, let's pour some of that savings back into this program so it can keep going. And then for the other resources, so like making sure that people's basic needs are met. And like you said, some of the issues that could compound the mental or behavioral issue are addressed. For that, you utilize fundraising.
Yes.
And total, you spend about $2.3 million.
Correct. Yeah, that's it.
That is mind-blowing to me because that is literally a drop in the bucket for our current safety budget. Most of it goes to our police, and it increases every year. So I think that the money is there. Can you elaborate a little bit more about how and why the efforts of CAHOOTS saves time and money, particularly for taxpayers?
Yeah. So let's start by talking about who would respond if CAHOOTS wasn't there. Just in the city of Eugene, which is where we've been operating continuously since 1989, since 1970, but technically with CAHOOTS since 89. Just in the city of Eugene, CAHOOTS teams were involved in 18,000 responses out of the 105,000 situations that were called in by the public. CAHOOTS teams were the only responders for 15,000 of those calls for service. And 13,000 of them would have required police, fire, or EMS to respond if CAHOOTS teams hadn't been available. So when we look at things from that perspective, our impact and our role in the larger public safety system, we see that the Eugene Police Department has verified that through those responses, we're saving the community $2.2 million just in officer labor. When we start to add in other things like reduced ambulance rides, if somebody's going to the hospital, or just reduced visits to the emergency room to begin with, there's another $14 to $15 million that our community is saving by having CAHOOTS respond instead. So for a program that has to fundraise a significant portion of its budget and is still only $2.3 million a year, we're saving $17 million a year to our community. That's before we even factor in the more challenging to quantify savings around, fewer arrests, right? Fewer nights in jail for quality of life offenses. That person is getting charged with criminal trespass too, because they're guilty of sleeping while poor. We aren't thinking about how many fewer jail beds are being filled because CAHOOTS teams are out there responding too. And once we start to really kind of look at that larger impact and the role that this mobile crisis can play in prevention, it really starts to become exponential when you're digging in to look for that cost savings.
I completely agree. I think, I'll definitely have to continue to talk to some experts about this to really convince the taxpayers that this is a fiscally responsible thing to do. Because again, my hope is to, again, fund this out of our city budget.
Sure.
And so one of the questions that gets posed is, well, you're telling us on the one hand, CAHOOTS saves money, but they're also not operated by our local government. But if the program in Cincinnati is operated by the local government, how does that then save us money? Like, is that not just, reallocating it and spending it differently? Is there actual savings there?
Yeah.
I don't know if you have anything to add to that, but that's definitely something that I am continuing to look at for the people who validly ask that question.
Sure. There's a big attention on the CAHOOTS model of mobile crisis intervention as a tool to address the needs of our neighbors who are experiencing homelessness, or for these very profound, high acuity, mental health crises that have escalated to the point where, it's this very public event, lots of, attention, potential for a lot of police interaction. We don't think as much about the prevention side of things. If you have a resource that can come out and talk to that person, maybe the first time they're experiencing a manic episode and they're pacing around their apartment at 3, 4 in the morning, starting to upset their neighbors, right? We can identify, okay, so this is an issue. It's affecting your immediate community. What can we do to find you some support, right? And then maybe we can, if everything works out, maybe we can get that person connected to the system of care that's going to work for them, so that they can have something to do to address that manic episode the next time it occurs, preventing them from having further conflict with their neighbors, which could result in them getting evicted from their apartment. So it's a lot of those types of situations where it might not be a direct dollar for dollar cost savings of having a different first responder get in there, but we have to think about that larger system of care, right? And how these programs can reduce population health spending. That there's an opportunity to really engage with people in a different way to increase awareness and really ramp up the prevention that this resource can bring to a community.
That makes sense to me. I always say, homelessness is fiscally irresponsible,
Yeah.
and it's just poor stewardship of our neighbors. And prevention is fiscally responsible. It's much better to prevent an issue than to just respond to it over and over and over again. So I completely agree there. As I've been talking with residents here in Cincinnati about this plan, one question that comes up is how do you learn to delegate the calls? So in other words, how do they know if this is a medical emergency, something that the police need to respond to? Or how do they know to just automatically send CAHOOTS? How is that delegated, and how is that process? How was that process of learning how to go about that?
Yeah. So here in Eugene and Springfield, the process of determining what it was that CAHOOTS would respond to really started by looking at what community needs were, and then where our CAHOOTS responders could have a role to play in addressing those needs. We develop a very comprehensive scope of work in our contracts with the cities of Eugene and Springfield. And then each of those bullet points from that contract translates into a call type that dispatch can already, it's a pre-existing code. So we're not asking dispatch to really kind of reinvent the wheel, that these are call types that would already have, a response assigned to them if CAHOOTS wasn't there. So, from a logistical standpoint, it's a very straightforward process of get the right language in the contract, and then that translates into something that dispatch can use. But I think, on a larger scale, and, where I've been able to spend a lot of time with other communities, is really recognizing that this is one of the key areas that lived experience needs to have a dominant role in. Cincinnati, Columbus, any community, Denver, Colorado, needs to take the time to really listen to the people who are being impacted by this over policing and the inadequate response to their needs. And from that, really identify what it is that you want your crisis team to respond to, and then ask the questions of how does this fit into that larger response system. So starting from scratch, this really needs to be founded in the experiences of those that you intend to serve with this program.
100% agreed. And I appreciate you advocating for that community buy-in and community input. Another question that I get quite frequently is, what happens if, or have there been experiences where, so you're working with someone and they become violent, which I guess the second part of that question is, how are your team members of CAHOOTS kept safe in their respective roles?
Yeah. So let's talk about the, responder safety. that process really starts in our training. And it's not just that de-escalation skill of empathy and active listening, right? When we're looking at safety in our response, we need to consider the patient's experience, the responder's experience, and then what the community at large is going through in that moment, and really pay attention to all three of those things as interwoven components of the intervention. If it's howling rain and wind, I probably don't want to have a conversation with somebody in crisis out on a street corner, right? I'm really forcing them to stay in that discomfort and potentially reinforce our power dynamic because I've got a nice rain jacket on and I was just in a warm van with, a heater. I'm protected from the elements, right? So what can we do to, address that physical safety for the patient? Can we have them come and sit inside the van where it's warm? Can we tend to some basic needs first so that person can represent themselves better? And can we mitigate some potential escalation just by getting blood sugar into a better place, right? But before we've even started to talking to the person, we need to think about the message you send in the vehicle that you respond in. So the CAHOOTS vans don't look like a fire engine. They don't look like an ambulance. They don't look like a police car. So that sends a message that this isn't those traditional systems of care. Then when we get out of the van, you see that we're wearing a t-shirt and hoodie, some jeans and work boots. We actively avoid keeping a bunch of extra supplies on a belt because if you have, vision impairment, and maybe you can just see the silhouette of that person walking up to you. If I've got a multi-tool over here and a little pouch with my extra gloves on this side, that might look like a holster. That might look like handcuffs, right? That might be a taser, right? And so we got to send a visual message that we are not that same kind of system.
I'm going to jump in for a moment. This is something that I really try to stress to people over and over again, because if you're talking about someone who is truly in crisis, if we're talking about like psychosis or something like that, even though the individual, for lack of a better term, is kind of out of their own mind, their brain is still scanning to try to keep that individual safe, even though a lot of those functions are kind of not working properly. That primary function is still intact. So your brain can still recognize like, okay, what is something that can potentially threaten me? And because you're in a state of escalation, it's going to continue to escalate you because it's trying to keep you safe on top of everything else that you're going through. The issue that happens is if you have a police officer, it could be the most well-intentioned, pleasant, most well-trained individual coming in to help this person. The brain is still going to recognize something that individual is carrying. And because the brain's function in that point in time is to keep that person safe, it's not going to focus on the fact that this person seems nice, they're talking to me pleasantly, they don't appear threatening. The brain's going to focus on the gun or the nightstick or the taser that they know that they have. Escalation worse just by the presence of having something like that. So that's just to add to the point that you were just making.
Yeah, and you think about pre-pandemic when, we would be gathering with friends and family at the park for barbecue and you hear the lights and sirens go by, you're not doing anything, right? They're not even coming close to you, not even hitting the parking lot, but you still, right, you kind of tense up a little bit, like you still feel a little anxious, and so we got to recognize exactly, when somebody's in crisis, the amygdala is taken over, it's that lizard brain, people call it fight or flight. And so we have to send a visual message that we are a different kind of response. We follow through on that by interacting in a different way. We're not training our staff to be warriors and to assume that every person they talk to could potentially turn into a fatal interaction, right? We are teaching our responders to approach these situations with mutual trust, with compassion, through least intervention necessary, and by providing a response that's voluntary. When CAHOOTS is on scene, people in our community know that they're not at risk of having their rights taken away. And so, you really combine all those different components and then add to that the fact that we are carrying a police radio. CAHOOTS teams are being dispatched over shared frequencies with patrol. And that means that if things do escalate beyond our ability to, manage on our own, we do have the ability to call in that very immediate support. And when officers show up on scene, we still have an opportunity to get this back into a de-escalated and voluntary space. I do think it's important to recognize the frequency in which we have to call for that police cover. I mentioned that CAHOOTS teams were involved in 18,000 calls for service in the city of Eugene just in 1 year, that we did 15,000 of those without anybody else showing up to help us. We only had to call for police cover 311 times through all of those interactions. That's less than once a day. And what we see when we break down those numbers is that it's a pretty even split between situations where as voluntary service, we can't mandate somebody go to that higher level of care. And so where we needed an involuntary hold to get somebody to the hospital for further evaluation and physical aggression. So it's about 150 times a year where somebody's going involuntarily and we need police support, and about 150 times a year where we need that police support to de-escalate things. So it's, we're talking about something that's a less than once a day on average issue for our teams.
So your teams are safe
Yeah.
is what I'm hearing.
By and large, yeah. We've never had anybody on the team seriously injured as a result of patient contact. There's the occasional scuffle. Sure, we're oftentimes responding to folks who have had their very humanity denied on a daily, if not hourly basis. And with that, comes some reasonable desire to maintain safety for yourself.
Mm-hmm. Are there other protections in place, like, basic self-defense? Do you send them with bulletproof vests or anything like that? This is just my own curiosity.
Sure. Yeah, we're not wearing a bulletproof vest, right? We're not carrying a taser, or it's important to recognize the police call these less lethal. That means they're less potentially lethal, right?
But not,
so we're not carrying
lethal.
a taser. Yeah, we're not carrying a taser or pepper spray or anything like that. We really rely on our ability to communicate and our work to triage these calls appropriately with dispatch to really maintain that staff safety. There's also just really, it's amazing, what you can do when you're just responding in a different way than somebody's used to with police.
There's one time, this is a pretty different situation. I work with elementary age kids primarily. I work two jobs, and one of those is working with adults, but primarily I work with children. And, we had a situation where, we had a kiddo who was unsafe. They were throwing things, heavy furniture, at risk of hurting themselves or someone else. So they were restrained, and, their legs were kind of held to the floor, and they were upset, obviously. And, one of the ways that I was able to de-escalate them was I just laid on the floor right next to them in the same situation that they were in. And they were very quickly able to calm down, because they're like, oh, wait, there's someone who's like at my level, speaking, like literally laying flat on the floor, an adult talking to me. So I think there's just an importance of, just recognizing I'm not here to threaten you. I'm not here to punish you. I want to understand. And the way that I'm going to do that is get on the floor with you. Or, hey, come meet you at the park that you're at, whether it's, super hot outside or raining and storming. And then once I'm there with you, let me present you with some alternatives in a way where you are still in control and you feel safe. I think that's incredibly important. About how many hours do your teams, for how many hours are your teams trained?
Yeah. So when you come to work on CAHOOTS, regardless of what kind of a background you have, you're going to go through about 30 hours in the classroom, where we're really focusing on a lot of the logistical side of things. What does it mean to wear this radio? Who do we refer people to, right? The nuts and bolts. Then we take that 30 hours of class time and then pair you with response teams out in the field, where you're out there taking calls as kind of a third member of that 2-person response team. And it's been our experience that it takes folks about 500 hours to get through the field training process before they start to work as a responder on their own in those 2-person teams. So that's, 530 hours all said and done between classroom and field training, compared to, at best a 40-hour CIT course for an officer.
That's literally, I think in Cincinnati, what our officers currently undergo is a 40-hour training, is focused on de-escalation and some psychological knowledge in there as well. So 530 hours. If you didn't hear that, I want you to hear that again. 530 hours. And in Cincinnati, I would not want that expectation to be less. I would make sure that individuals are adequately trained. And this means that this is going to take some groundwork to get off of the ground here in Cincinnati, but we will get there. I have faith. One specific question, as I was having this discussion with some folks on a local politics group, was, what happens if, CAHOOTS arrives on the scene and they learn that, wait, this isn't necessarily a behavioral or a mental health emergency, there's a medical issue going on here. How are they trained for that, or what are they able to do?
So that's why we carry an EMT with us at all times. Anytime you see the CAHOOTS van in our community out responding to calls for service, there's going to be an EMT basic or higher and a crisis worker. And like I said earlier, we really recognize that there is always going to be intersectionality between physical health and behavioral health. And we need to approach every situation as though it could become, start off on one side and kind of float over to the other side of the spectrum. And so we have that EMT right there. And because we have an EMT as part of our response, we're actually able to handle and facilitate a lot of responses that would otherwise go to, a fire engine or an ambulance company to address, wound care, right? That person who may be using drugs intravenously has an abscess that was drained to the hospital and they just need somebody to come and check on it. That's a call that doesn't need the fire department to respond to. So we can take a lot of those responses just carte blanche. But if we do get into a situation where there is that profound medical emergency, then we're wearing that public safety radio. And just like we can call for that, patrol support when we need it, we're able to directly speak with dispatch to get our partners in EMS to come out and support us. And, there are always ways that we can, kind of support those responders when they get on scene, be it talking to other witnesses or, addressing whatever the needs of the situation are.
That makes complete sense. And if I remember correctly, STAR in Denver kind of does the same thing. They have, their social worker, their mental health specialist, responder that's paired with another individual. And I think they're an EMT as well, if I remember correctly. Can you tell me a little bit more about some of the programs, throughout the country that CAHOOTS has played a role in helping get started?
Yeah, we spent a lot of time in the Bay Area, in Oakland and San Francisco, and we're able to support the initial efforts around macro in Oakland, as well as various initiatives that have taken place in San Francisco over the last couple of years. You mentioned the STAR program in Denver. We also helped set up Olympia, Washington's crisis response unit and Portland, Oregon's Portland Street response. Right now, we're actively working with a couple of different communities on the East Coast and in the Midwest, and are hearing that there are programs inspired by the CAHOOTS model throughout Canada that are really popping up. We also see that the CAHOOTS model has inspired a lot of efforts down in Southern California. Huntington Beach just announced that they're implementing a crisis program. And I've had the privilege to, panel and speak with, hundreds of communities throughout the US and Canada over the last couple of years.
And now add one more to your list, being
Absolutely.
Cincinnati, yeah. Ohio. And again, we really, really appreciate it. One of the biggest pushbacks that I receive, and, to give some context for this as well, I think a lot of people have the impression that this is something that police don't want. And I want to make it clear that, while of course I have not spoken to every single police officer or law enforcement officer in the city of Cincinnati, those that I have spoken to typically have one of two responses. It's either, yes, that sounds great, or yes, that sounds great, but I doubt it will happen. Part of that is, we do have a mobile crisis unit team in Cincinnati already. They're operated through UC Medical, and they are actually contracted with our police department. But I'm trying to navigate this carefully because I don't want to paint what they've done in a negative light. They are very important and have been very helpful, but it's not always the most accessible. And from my understanding, what's happening a lot now is it's more of a resource for police officers than it is, individuals actually going and helping either transport folks to the hospital or even intervene with a person one-on-one. To the degree that right now there's a big push for all of our police officers to carry iPads so that they can do telehealth with the individual, which I think is pretty interesting. But, it is what it is. We'll just put it that way. And I think that's one of the reasons why some of our police officers are kind of like, yeah, I don't necessarily think that this is going to happen because we've had a mobile crisis unit and it's not like what you're presenting. But then when talking to citizens, one of the things, oh, I think I lost Tim for a minute, but he will rejoin shortly, I'm sure. While we wait, for those of you who are continuing to join us, please feel free to join in with any questions, comments, feedback. This really is supposed to be informative for folks who, especially those who don't believe that something like this could be possible in the city of Cincinnati. I think that skepticism should be rewarded with answers. So if you have specific questions or things that you would like to hear more about in this regard, please ask. And, while I am trying to pioneer and spearhead this issue in Cincinnati, I don't know everything. So your question may be something that I've never considered before. So please do not hesitate to ask. Logan, I appreciate your feedback. We're just going to give Tim a couple more minutes to see if he can get back on. Hopefully everyone's doing well who's attending, whether you're watching this live or watching this later. I hope that everyone's doing well and that this is fun and informative and exciting for you to hear more and more about. So I'm going to briefly turn off my camera here and see if I can shoot him an email to see if I can get him back on. We will start back very shortly. Okay. So I was just kind of, previously talking about our current mobile crisis unit and where there is, room to expand. Was there a part that you would like me to pick up from that maybe your internet cut out at a certain point?
No, I think I've got, what would be different about this, and I think a lot of that hinges on first and foremost the accessibility piece that you brought up. With the CAHOOTS response that we have here in Eugene and Springfield, our teams are on duty 24 hours a day, 7 days a week. Because we are integrated into the larger public safety response system, just that, we're contractors doing this instead of city employees, our teams are immediately available, regardless of, regardless of whether or not police got involved initially, right? We're going to be showing up at the same time, that we would, no matter who's requesting us. And you compare that to a lot of more traditional mobile crisis where, yes, it is a referral that they may want to try and address over the phone, or that there may not be a response for up to 24 or 48 hours after, that there's just a different pocket for that kind of mobile response. Oftentimes what we see with those situations too is that because the staff teams are generally, licensed professionals, there's a lot more that's happening around potential connection for civil commitment, or at least, hospitalization, that there's potential for a diagnostic work. And with CAHOOTS teams, we are not obligating our crisis workers to be licensed, clinical social workers, right? LPCs or anything like that. Our job is to de-escalate and find stability in the moment. And so our obligation is really kind of in, I think, different places than this more traditional mobile crisis team.
That does make a lot of sense. And that gives me a lot to think about for sure. So one of the questions that I get a lot is, why not just hire more police officers, and why not just train police officers to do all of this? I have my thoughts on that, which I'll share, but I would love to hear yours if you wouldn't mind sharing.
Why not have police officers respond to take you to the hospital when you have a broken leg or you're having a heart attack, right? There was a point in time prior to 1967 where the best chance you had of getting to the hospital quickly when you're having a medical emergency was if the police were close enough to get you, if they would respond to your neighborhood. And if you didn't have that, then your other option was, maybe the morgue can take you. So there just weren't a lot of what we consider options as far as EMS and paramedicine. And it wasn't until the Freedom House in Pittsburgh started to try and find a way to address the fact that police weren't responding to primarily Black and brown neighborhoods for medical emergencies that developed what we all take for granted as the traditional EMS system nationwide, right? And so I think that we're really kind of in the same spot right now where we keep obligating police departments to respond to situations when there is nobody else available. And we need to allow, every aspect of public safety to be able to do their job well. And that means giving them potentially kind of fewer things to focus on. And so just like, our nation was willing to take that leap and apply paramedicine the way we all see it today, now based on what was happening in this, one area in Pittsburgh, I think we have an opportunity to really look at, what would it mean if we created a behavioral health first responder, in public safety systems across the US.
I agree. And, kind of the response that I usually give is, we could we could train our officers, for hours upon hours, but if you're looking at models, which I'll admit, the model that I kind of have in my head, relies heavily on licensed individuals.
Mhm.
And I think that is an unfair expectation, because a licensed individual is going to come in with 4+ years of higher education. That's not something that we can really realistically expect, police officers to be trained to do. I mean, when you have a social worker, a therapist who's responding to these, and they're told, okay, well, this individual is known to have bipolar 2 disorder. They recently got off of their meds and may have smoked marijuana, and they're in a hypomanic state. An LPC is going to be able to translate a lot of that kind of immediately. That's very unfair to expect a police officer to be able to do the same thing, or to try to train them to do that for all of the different, diagnoses or things that could be contributing factors, unless you want to spend years and years and years of taxpayer money doing that. If that's what you want to do, then okay, I don't agree with that. But another thing to your point is, you would not expect, like you said, you would not expect a social worker to arrest someone or solve a crime. But when the roles are reversed, people seem to be okay with that juxtaposition. They're okay with asking a police officer to do what a social worker, a licensed therapist, or someone who is trained by CAHOOTS has been trained to do. But you flip the script and all of a sudden it's not okay. It's like, well, that's called a double standard and that's not okay. What would you say to cities or communities that are resistant to this type of operation and changing the way that they view crisis response?
Mhm. I mean, the first question is why? Where is the resistance coming from? Is it fear? Is it that you've spent the time really listening to your community and you are confident that your constituents need something different than the CAHOOTS model? Is it that you are really worried about the reaction from the police union if you do pursue this? There needs to be some time to really explore where that hesitancy is coming from, and then to sit with that. Maybe it's that a community isn't ready for that mobile crisis service, and that could very well be the case. The success of CAHOOTS, our cost savings, the ability to respond to so many calls a year as we do, is all predicated on our connections to the larger system of care in our community. And if we don't have adequate access to services to address those, emergent mental health needs, to address, basic human rights of, food, sleep, shelter, hygiene, right? If we don't have the ability for somebody other than law enforcement to take somebody to sobering and detox, then maybe the priority needs to really be around developing those services before you start to really pursue that mobile crisis team. The big question for me isn't so much does the community want this, but is the system ready, to bring in something like that? And then from there, it's what are your community members, what are the consumers of your mental health system telling you that they need with regards to that mental health response?
I would agree. And I think that that's something that, I can definitely slow down and ask myself, because, like I said, I'm really trying to push for this, mobile crisis to be something that is in Cincinnati in the next few years and begins to operate. But like you said, we may not be there yet. We may
Right.
have several steps that we need to take before we get to that point. And, I'm more than happy to consider those. Um, are there any other thoughts or just anything else that you would like to share before we conclude the evening?
Gosh, I mean, we've covered so much. The one thing that I really want to make sure it gets across whenever I talk to another community is about the opportunity for us to really bring in lived experience and peers in this work. That we have tremendous opportunity to really draw on that lived experience, not just in designing these programs, but by having a responder who can come out to you and say, look, I've walked this walk. I can tell you what it was like to go through the emergency room doors and be on the other side of that. I can tell you what the paper scrubs and the grippy socks feel like, and that there's a ton of power that comes with that. And so as we are talking about these programs, as we are talking about these responses, there can't be enough attention really paid to the perspective of the consumers of services, to that lived experience, hands down. That's the number one thing that I ask people to walk away with, is really, what are they going to do to engage that lived experience better?
I hear you. And I think at the end of the day, like, this isn't, this isn't politics. This isn't, just structures and systems. At the end of the day, for people like me and like yourself, it's how do we care for people in the
Right.
best way possible? And one of the things that I try to convey is that, I'm thankful for what we do have in place in Cincinnati. I mean, the fact that we do have police officers that receive 40 hours of training, that we have a designated mental health response team. I think that that's a big deal. And I think that that deserves recognition. But my question at the end of the day is that what's best for our most vulnerable individuals? If it's not, why aren't we striving for what could be better for them? It's not an us versus them thing. It's how do we take care of our most vulnerable individuals holistically and just in a person-centered manner. So that's the bottom line. And I hope that individuals that watch this and view this see that and really feel that is truly honestly the goal here. So Tim, once again, I really, really appreciate your time and your willingness to share your expertise and more about the CAHOOTS program. I may call on you again in the future if that
Please
is
do.
okay.
Yeah.
Okay, wonderful. Well, thank you so much. And to our viewers, thank you as well for participating. I am going to upload this to YouTube for folks who have not been able to watch live, so people can check it out there. But in the meantime, we will conclude for the evening. Tim, take care, stay safe, stay healthy, and hope to talk to you soon.
Absolutely. Thank you. And everybody, take care. Have a great night.
Take care.